Part 2. Pharmacodynamics and pharmacokinetics of PCP and ketamine.
In this part, pharmacokinetics and pharmacodynamics of PCP and ketamine, how the drug moves in the body from administration to elimination, and how the drug has its effects. First, let's look at the movement of PCP and ketamine in the body of a drug user. Pharmacokinetics. PCP can be administered in a variety of different ways, with varying effects and timetables. The most rapid effects can be achieved with intravenous administration or inhalation, which takes effect in approximately 1 minute. Intranasal administration also proceeds rapidly, having its effect after a couple of minutes. For oral administration, the effect is much slower, closer to 20 or 40 minutes, and is taken in the form of a pill. Another common approach involves sprinkling the powder on tobacco or marijuana, and smoking the mixture or soaking a cigarette in a solution of water and PCP. A more rare form of administration involves using eye drops with a solution of PCP or even administering transdermally. Lighter doses of 3 to 5 milligrams are usually smoked or taken intravenously or intranasally, while heavier doses of 10 milligrams are usually ingested. PCP is a weak base, and thus is ionized when taken orally. Due to the impermeability of the stomach lining to ionic solutions, the drug cannot be absorbed through the stomach and is water-soluble, due to its high acidity. Once it is absorbed into the intestine, a more basic environment, it is distributed to the rest of the body. Because PCP acts on NMDA receptors, which are found mostly in the brain, the concentration of PCP is much higher in the brain than it is in the rest of the body after use. Blood plasma of the PCP is about 65%, leaving 45% of the drug to have an effect to be excreted initially. Main effects of the high last for only an hour, but there are strong effects for 4 to 6 hours. Because PCP is readily absorbed into the brain via NMDA receptors and is highly fat-soluble, PCP stays in the body for a long time and is slowly released, having effects for weeks. This is especially true for chronic users. The effect is even more noticeable when losing weight. The PCP is stored in fat tissue, is released in the breakdown of the fat, and released at higher concentrations into the body. The half-life is highly variable, ranging from 7 to 50 hours, which an average of approximately 20 hours. PCP is metabolized in the liver by cytochrome P450-3A, resulting in a polar metabolite that is excreted in urine. About 20% of the drug is excreted unchanged in urine, while about 80% is excreted in polar metabolites. Approximately 80 to 90% is eliminated in 10 days, but this number is highly variable. Exercise actually increases the speed of elimination of PCP from the body. Pharmacodynamics. So far, we've learned that phencyclidine, or PCP, and ketamine are dissociative anesthetics that can act as an anesthetic blocking the sensation of pain, and as a hallucinogen. How do PCP and ketamine have their effects? PCP and ketamine have their primary effects on N-methyl D-aspartate, or NMDA receptors. Basically, the NMDA receptors require 2 receptor sites to be occupied in order for the channel to open. Glutamate occupies one side, and glycidine, or D-serine, occupies the other. However, PCP and ketamine can occupy the second receptor and prevent the NMDA channel from opening and letting the ions flow. Because NMDA receptors play a large role in glutamate signaling, and hence in exciting neurosystems, the blocking of the ion channels is thought to lead to the cognitive defects produced by PCP and ketamine. The concentration of NMDA receptors is greatest in the cerebral cortex and the hippocampus. Because the cerebral cortex is involved in everything from memory to awareness, and the hippocampus with things like spatial orientation, PCP and ketamine can have devastating effects lasting for weeks. As an anesthetic, the effects of PCP and ketamine occurs in 2 ways. They block potassium ion channels in the central nervous system, thus preventing the transmission of the sensation of pain to the brain. Also, NMDA receptors have been shown to aid the perception of pain. Thus, if PCP or ketamine blocks the NMDA channel, you wouldn't be able to perceive pain. Repeated exposure to PCP and ketamine leads to rapid tolerance through downregulation of the receptors on key target cells. However, repeated use of PCP or ketamine also changes the neurons around the receptor site. If the use of the drug is long and severe enough, the damage can be irreversible. This effect is particularly severe in fetuses and infants, where mass deletion of brain neurons can occur. But why would anyone want to take a drug with such damaging effects? Well, PCP exhibits high reinforcing effects. That is, it makes you feel good so that you want to take it again. Apart from the hallucinogenic side of things, there is some evidence from animal studies to suggest that PCP can act directly on the nucleus accumbens, which some have called the pleasure center of the brain. Additionally, PCP and ketamine activate dopamine and in the prefrontal cortex, which contributes to the neurotransmission of dopamine and thus to PCP's and ketamine's reinforcing effects. Let's recap. PCP and ketamine act on the NMDA receptors to prevent the channels from opening and thus severely depressing the central nervous system and then brain. Depressing of the central nervous system leads to anesthesia. Depression in the brain leads to schizophrenia-like symptoms, as well as hallucinations and psychotic behavior. While users of PCP and ketamine rapidly tolerate to the drug, they are both highly addictive and extensive damage to neurons can occur through prolonged use.